My name is Vasumati
这是雅各布里斯。
我叫李幼平，从中国大陆
제 이름은
My first Cochrane review was quite a controversial review at the time. It was a review of something called directly observed therapy, which is an approach to caring for people with tuberculosis. It ended up being controversial, as I said, primarily because we discovered there was no good evidence to support that intervention. And we published that fact, and the WHO and others were extremely upset about that because they felt that it sort of undermined their position on this.
For 20 years, Cochrane reviews have challenged conventional wisdom on standard health interventions.
To this day, I find this absolutely fascinating how we as a medical profession are absolutely in love with the treatment, with anything that kind of works or is statistically significant, and just can't cope when something that is close to our heart doesn't work, or somebody dares to say that there is no enough evidence that we do that. And this has not changed much over the last 20 years.
People tend to pick and choose the study which they're familiar with. Maybe it's from a major journal, maybe it's from their country, maybe it's in their language. There's also a fear of change. I mean, we all have a great deal of our own personal psychology involved in this.
When you've been doing something for dozens of years, or your whole career, and then all of a sudden there comes this guy and says, oh, what you're doing doesn't work, provokes all kinds of reactions that are usually not very nice, you can imagine. One important review which had a lot of impact in the field is a review about training and education for people that do lifting in their work to prevent back pain. So we did a systematic review, and to our surprise there were 9 randomized controlled trials, and none of these randomized controlled trials showed a preventive effect on back pain. So there was actually a shock for many people in the field who had been doing these training and education sessions and saw this as a core of their occupation. So first people started arguing that this must be a bad review, that must be flawed, there must be biases in the review, it can't be true. But now we have done more reviews, shown that the methodology is good and sound. People are more inclined to accept that, well, maybe this is not true, and we should find alternatives for doing this.
I didn't have any interest in mammography screening, and I didn't know anything about it until I was asked in 1999 to review the trials for the Danish Board of Health. And this was because there had been a Swedish study that couldn't see any effect of mammography screening in Sweden, which was one of the first countries to start mammography screening. So we did this report in just 4 weeks and concluded that it was doubtful whether it worked, and it might even do more harm than good. We were asked to do a more detailed review. I mean, 4 weeks is not a long time. And we even got funded for doing a Cochrane review, which we then did. But the interesting thing is that what we still say about mammography screening today, 12 years later, but with much more data, is that the benefit is small and much smaller than what has been claimed. And there is a lot of overdiagnosis. You convert a lot of healthy women into cancer patients unnecessarily.
The evidence has to really be so convincing to make a change. And frankly, the evidence itself does not get people to change. There has to be authority behind it. There has to probably even be national consensus behind it. When people are left to their own choices, they will read into it what they may.
While many Cochrane reviews have found a lack of evidence, other reviews have clearly demonstrated effectiveness. This was the case for Peter Langhorn's work on organised stroke units.
At the time, people believed that
organising the care of stroke patients in hospital in one place with staff who are interested and experienced. They thought it was a good idea, but nobody really believed it changed outcomes. And what we managed to do, it was actually very much an international initiative, but we managed to pool together all the data from all the trials around the world and showed that there were actually potentially quite important benefits in things like your chances of surviving and returning home after you've had a stroke. And so it was an incredibly sort of exciting result, and I think it kind of galvanised the stroke community to really get services much better organised. It has really sort of become the cornerstone of a modern stroke service.
So I lead the national scale-up of Zinc in Bangladesh, which is a project that I inherited. In most developing countries, children simply don't get enough meat or zinc in their diets, and they're at all sorts of health risk. The number one message you can take away is that what we proved both through rigorous randomized controlled trials, not just in Bangladesh, but globally over a period of about 10 years, that were then systematically reviewed, is that zinc is almost a magic bullet for saving the lives of children under the age of 5.
খাবার পানিতে বেবি জিঙ্ক ট্যাবলেট দিলে এমনিই গলে যাবে। তারপরে গলে যাওয়া পুরো ট্যাবলেট আপনার শিশুকে খাওয়াবেন। মনে রাখবেন 6 মাস থেকে 5 বছরের শিশুকে
And so I've actually been on the leading edge of taking what came out of the basic science and a systematic review and making it a living, breathing reality in a nation in South Asia. It's been the work itself is incredible, and it's something that shows that systematic reviews can save lives in developing countries. We believe in Bangladesh, if we were able to reach 100% of the children, that we could save about 50,000 child lives per year.